name is Anissa. I am the Chief Program Officer from PMD Alliance, and I am just getting back from ATMRD. My brain is a little bit fried still, but what I want to talk about today is related to that. And I'm very excited because I feel like we did something unique, and I will be sharing some of that information. Clemmy was there, a part of it. Carol was there and a part of it. So definitely I'm going to invite them to give their thoughts and feedback on it. But I want this to be interactive, so we're going to do it as we always do, and have our discussion, and then you guys will go into your breakouts and be able to talk about some of the questions that I have for you following today's discussion. And hopefully more people will come, but maybe if we don't have enough to go into too many breakouts, we can go into at least a couple and then come back. But I know people may be joining late. So I'm going to share my screen to get us kicked off. All right. Are we good to go? All right. I'm getting the thumbs up from Kelly. All right. So you guys know basically these rules of engagement here. So one of the things that we're going to be talking about today, I really do want you to listen and think about this perspective. We obviously always want your perspective, and we want our healthcare providers to hear your perspective. So what I'm going to be sharing today is the empathy and action session that we did at ATMRD. First of all, before we get into that, I want to get to know you all a little bit and start off with our chat storm. So I'm always, curious where people have been or where they dream to go on vacation, and I'm ready to go on vacation. So I'm curious, if you had an all-expensive paid vacation to anywhere you could go this summer, where would that be? So I'm going to kick it off, and I'm going to go with the first square that I see, and that's Greg.
Hold on. There we go. All expense paid. I'd go to New Zealand. I've been there before, and phenomenally beautiful mountains, ocean, rivers, fishing, nature. I did more fun things in New Zealand than I've ever done. It's the only place I've ever hiked to a lake that had floating stones on it. They were pumice stones. The New Zealand, that island chain, is a relatively new volcanic island. And I've never seen stones floating around on the water before. And that was an amazing deal. So I would say New Zealand.
I've always wanted to go to New Zealand myself. Just, it's gorgeous, lots of great hiking there. So I would agree with that one. That's a good one. All right, Myra, where would you go if you could have an all expenses paid?
I would go to San Francisco to visit my daughter.
Nice. I love San Fran. I've been there a couple of times. It's a beautiful city, but even better when it's your loved one, your daughter that's there. Do you get to see her very often?
She was just here, so that was good.
Good. Awesome. All right. I have Karen next. I guess there's two. So Karen, Santa Cruz, California. Karen Williams.
Hi there. I think a chartered flight around the world would be nice, but since that will never happen, maybe a cruise on the Great Lakes or a cross Canada train trip.
Nice. I bet that would be absolutely beautiful. All right, Carol, where would you go?
I would go back to Italy. I actually won a trip to Italy from a wonderful gentleman who had a PR firm for years. His name was Bill Wilkins, and he had Parkinson's. And I bought the most tickets for a drawing. So I won a fabulous trip and took a really good friend of mine. But it was during the winter, and a lot of stores and a lot of things were closed. So I really want to go back and do it again. And this time I might have to pay for it.
That's exciting to be able to win and get to go.
It was amazing. We spent most of the time in Rome and had a villa in Tuscany. And because I didn't have to pay airfare or, for the villa or anything else, I hired a driver for 4 days out of the 7 who was born and raised there. And he just knew every place to go and every restaurant that we could go to that, was not the real popular go-to. So I'd love to be able to go back and hire Paolo again.
Having someone local driving you around, giving you all of the background information is wonderful.
It's just the way to go. Yep. You just have to be able to afford it. I'm sure his fees have gone up a lot, just like everything else.
All right, Lori, where would you go if you could go anywhere, all expenses paid?
Who did you ask?
There you go.
I would do a train up through the Canadian Rockies. It's on our list, but we can't get it off the list.
That's nice.
That'd be,
I've looked at those before. They look amazing.
yeah, they're like a lot of money though.
Aren't all the good ones? They're all very expensive, but it would be nice if someone paid for it. So I would
Maybe
definitely do it. I think Judy stepped away from her computer for a second, so I'll come back to her. Katie, you're next on my list. If you could go anywhere on someone else's dime, where would you go?
Oh, definitely the Maldives. So I have gone to Alaska, and that was absolutely beautiful, but I'd like to go somewhere warm with clear oceans.
That sounds good to me. All right, Karen Patterson, how about you?
Well, Alaska does sound nice, and I know it's absolutely gorgeous. I think I would have to, yes, and I think Myra's the one that said it, and take the all expense trip to go see my son in Massachusetts. I'm not far from San Francisco where I am now, so yeah, that would be probably my topper. Go see all the things I didn't get to see the first time I went, because yeah, we did that on a shoestring budget, and there was a lot of stuff we didn't get to see. We had a good time. I did get to see a lot, of course, got to see my son, but yeah, I would like to go back and see all around Massachusetts. There's a lot of things we didn't get to see, so that would be it.
Nice. All right, Judy, I'm going to come back to you. Where would you like to go?
Unmuted. Okay, am I heard?
Yep, we're hearing you.
All right, well, Karen, I might have to call you. My fantasy would be to go back to New England and have a chauffeured limousine take me from Connecticut up into New Hampshire and Maine and Vermont and visit all my cousins that I haven't gotten to see for a few years, and do it, where it doesn't, I don't have to do any driving or rent a car. I just want to have the limousine service all over New England. And maybe Karen and I can get together, and anybody else out there, we can split the cost and really go.
That'd be neat, because Pat's in Lowell, and he actually lives in Boot Hill, which is a historic building. There's a museum and everything.
Oh, he lives near Boston?
He lives in Lowell, or actually at
Oh,
Lowell, I
Lowell.
think is
Oh,
where
I've taken, we shouldn't be talking on this.
I'm sorry.
I've been, yeah, I actually have cousins that live right next to Lowell.
Neat. Yeah, that's where he is.
Okay.
We'll
This is
talk
part
another
of
day,
it.
Judy.
This is the
Bye.
connection part. Like, I would like to join
Anybody
you with
else
that.
out there?
So I know someone who knows someone, you know,
Yeah, you never
it's
know.
a small world.
Yep.
All right, Corey, how about you?
Well, being a person who lives in Massachusetts, so I hope that Karen and Judy would come and visit me in the Springfield area, Western Mass. Let's see. I've always wanted to go see Mount Rushmore. I have no idea why, but since I was a young child, I always could not imagine somebody carving presidents' heads into a mountain. So I've always wanted to see that. But if it really was all expenses paid, I'd really want to go someplace really exotic like New Zealand or Australia or on safari in Africa. Really see something really different and special. Oh, New Zealand, I understand, is absolutely gorgeous. So, and I'd love to see black swans and koala bears.
Mm,
Yeah.
definitely. Hi, Maria. How about you? If you could go anywhere, all expenses paid, where would you go? Oh, and you're muted.
Hello, I'm sorry I couldn't see you guys. It's so good to see you. I miss you guys. Well, I guess, if I had all expenses paid, I love to go to the beach, even though I don't do well in the heat, but I still love the beach. I like to go to the Turkish Rivieras, or this summer my daughter is going to go to the Arctic Ocean for expedition to Iceland and Greenland. So that would be something fun to do with her. So
That would be. How exciting.
yeah, I'm so excited for her. But a little scared too, being in the ocean the whole time and with all that ice and things. But although it's the summer, so
We have to report back how it was when she's
yes, yes,
returned.
yeah. She's gonna be gone for a month in August, so we
Very
definitely
exciting.
will.
All right, Randy, where would you go?
Well, we have a trip planned. It would be nice if all expenses were paid, but we're going to the Italian and French Rivieras next summer.
That sounds so nice.
Yes, can't wait.
I'll just tag along with everybody else because you're all going to really different and really nice places, and I'd like to do all of them. So, okay, Lorenzo, how about you?
I'm a big fan of Oaxaca, Mexico. It's a historic city built on a mesa that's at the confluence of 5 valleys in Mexico with lots of historical stuff. And it's just a beautiful city.
I think that it's from there, but there is some artwork that I actually brought back from Mexico, not from that part, but I think it was made in Oaxaca. It's like wood and they paint it these very bright colors. I'm pretty sure it came from that area.
I think you're talking about the fantastical creatures that they create down there.
Yes, yes.
And I can't remember the name of those.
I have a dog and a cat from there. They're really fantastical. They're really cool. I love them so much.
Yeah.
All right, I think we got everybody except for Clemmy and Kelly, although they did drop some things in the chat. Clemmy, I'm going to join you in Tuscany. We'll rent a villa and we'll just park there for a while and enjoy all the wine and all the food. And Kelly, how about you?
Safari, specifically elephants.
Yeah, that would be great. So there's too many places that I want to go. It's really hard for me to pick a place. So Tuscany is definitely one. New Zealand has always been on my wish list. So I'll tag along if you guys get to go. So thanks for sharing that. It's always kind of interesting to see where people want to go, and it certainly puts exciting ideas in my head. So how do we figure out to get the all expenses paid thing done? I don't know, but you figure it out, share with the group. So okay, so I want to talk about this event that we did at ATMRD, our Empathy in Action. This was a multi-sensory experience, and Lori was there and a part of it, and Carol was there and a part of it. And did we lose Lori? Because I saw her. No, I don't see her. She must have fallen off. So maybe she'll come back, because she was there. And it was really an incredible experience. So I'll share a little bit about what we did, the stations that we had as we did different experiential stations, and then some feedback that we received from the participants. But this was the kind of the description of this experience for the participants. It's to basically to step into their patient's experience and help them with their communication, help them with their influencing and treatment approaches, to foster a deeper understanding of symptom burden and the need for personalized strategies. It was a multi-sensory hands-on experience designed to simulate, obviously couldn't completely emulate, but to simulate motor and non-motor symptoms in Parkinson's and related disorders. So we had started off the morning with a breakfast experience where Kelly Papish, who is a nurse practitioner, who is a part of PMD Alliance and also the executive director of AMDAP, which is our Association of Movement Disorders Advanced Practice Providers, she went through some of the challenges for nutrition for people who might be dealing with slowed eating because of bradykinesia or swallowing issues, tremors that might make it difficult for people to eat, and just kind of explained that it's not just the physical symptom impact, but it was the mental and social impacts. And then what we did was we asked people just to get an idea of maybe some of the challenge or discomfort, and obviously not to the degree that anybody with lived experience would have, but to start with things such as eating with their non-dominant hand. Some people are ambidextrous. So one person's like, yeah, I'm ambidextrous. It wasn't such a big deal for me. But most of us aren't. And they weren't allowed to use flexion either. So they had to just, use their hand, not bend it, not lean forward to scoop food into their mouth, but to experience not having complete control the way that they're comfortable with, or, not using their dominant hand in any way to assist them. So that was the first thing that we asked them to do. Then the second thing we asked them to do was to chew their food for a full minute. There are people that obviously that chew for a while, their swallowing may be delayed, it makes maybe eating a lot slower than it used to be. And while this isn't going to completely emulate that experience, we timed them for a full minute, and full minute seemed like a really long time for people. So they had that experience. And so I will share some of the feedback and the data from that. The other experiences that we had after breakfast is then they broke out, and we had in a side room, we had a gait and motor station where they would have to wear ankle weights, and they had resistance bands around their legs to kind of mimic what it might be like to have reduced leg stride, or just the heaviness of feeling. And then they did a freezing of gait experience where they walked with Velcro shoes across the mat and their feet would get stuck. And it was with the weights and with the bands, how it might be like to feel stiff and heavy and stuck. So that was one station. Another station we had was a taste changing station. It wasn't taste dimming per se, but it changed taste. So they ate these, what they called snozberries. That's not, I don't know, that's what the real berry is called, but it's these berries that you chew and then it makes food taste different. So we had them eat slices of lemon, and instead of the lemon tasting sour, it tasted sweet. And so it changes what things taste like, just to help people see what it might be like to eat something and it just doesn't taste the same that it did, or it may not taste anything at all like it did. The other station was our dysarthria station. And so what they did for that is they had people have a bite of a marshmallow and then try to talk, and then somebody else wearing earplugs and trying to listen. And kind of what it's like to have a hard time with articulation. And so that was a really interesting one. We had a dexterity station. People had to wear their entire hand in the mitten without using the thumb hole, and then try to button, zip, buckle a belt, and fold towels. And while they could fold the towels and do those things, it was really challenging. Obviously, this isn't an exact replication of what it would be like to have diminished dexterity, but they got the idea of how it can slow things down. And if somebody's trying to get ready in the morning, it can be very frustrating. Or one of the comments I heard frequently is like, I would just give up buttons altogether. And so they're like, wow, like I can imagine how challenging this would be to like have to completely change your wardrobe and the style of clothes that you like to wear, or, you know, you have to plan out your day because it takes longer to get ready. And so it was interesting to hear their perspective as they're going through it and how frustrating the experience was for them to try to do these things. And then the other experience in that room was a VR experience for those who have Huntington's chorea. And I did this experience. I'm going to be honest with you, it made me cry. And I think I told Clemmy and Kelly this, I think part of the reason it made me want to cry was because I was also watching all the other experiences in that room and hearing the comments. And you know, how impactful it was. And then I sat in the seat of that VR experience. And for those who have chorea, or even relates with a tremor, like how they couldn't hardly control their hands and manipulate things the way they had previously, the dexterity, but it wasn't just that. It was also what it was like emotionally and the relational tension that was going on, because you could hear the care partner, the wife, responding to all the different challenges and how it kept progressively getting worse, and the pain on both sides. And so this experience really captured that dynamic amazingly, and was very, very powerful. In the other room, we had our ambassadors. Actually, what we decided to do, we were going to do, I think we talked about doing role plays, but we ended up simplifying this, and we just sat at tables and had the participants go to each individual table with different ambassadors, and they were asked questions by the ambassadors, and they were asking them pointed and deep, you know, probing questions to kind of get their thoughts on things from the perspectives. And so actually Lori was there, Carol was there. Can you share some of the questions that you asked and what that was like for you? And we'll start with either one of you. Lori, okay.
In case I have to hop off again. One of the questions that really got me was what's your greatest fear if you would be diagnosed with Parkinson's, what would your fear be? And they were I had a younger clinician at my table, and she said like the exact same things that I said. Like she said she was afraid she couldn't be a mom, and she couldn't get, you know, like all these things. I was like, you were me. Like that was exactly how I felt. So you know, it was really kind of cool to see how much they actually paralleled to what was really real. So that was one of the better ones, I thought. I can't remember, they gave us like 8 of them on a piece of paper, and I'm like,
I know, and I wish I would have had them all ready for this conversation today, and I didn't. So
it was, what was your biggest fear?
yeah.
What if you only had 15 minutes with each patient that you saw, and it was a very rush day? How would you act, or how would you show empathy to that patient when you were
Or to the next patient?
Yeah. That actually, and as soon as I make a comment, I'll run get the paper because I know exactly where it is.
Okay, good.
That was the one about the 15 minutes and how you show empathy was a lot of discussion at my table. And what I was totally blown away by is that no one had 15 minutes. They go, we got 30, we got an hour for DBS, we have 4 hours in 2 sessions. And I'm going, where did the 15 minutes pop in? Because I didn't actually have anyone that had that short of a time period. And it was so interesting because they all had such great answers about how you just put everything out of your mind and you listen and you look at them and you look at them straight in the eye and you just do things that were just exactly what you would hope that you were trying to teach people to understand. So, and when we first sat down, I had like Stan Fisher and Sherry Gould and all these pros, and I thought, all right, this is my big challenge for the day. And then they all left and did something else. But I think the important thing, Anissa, and I'm glad I get to speak on this, we all went through all these, different models about who should ask what and how should we do it. And then just the night before, when you all decided, just don't do that. We'll put all the questions on a piece of paper and kind of play it by ear. And I think that that just made it so powerful. I'd love to hear what Lori thinks about that, because people were kind of free to talk about what they really wanted to talk about. And to be able to hear people, especially the ones that I know have Parkinson's disease, say this is like the best part of the conference for them. And the whole conference was just incredible, just incredible. So I thought that was very powerful and turned out to just make it so, so meaningful. And I must comment on the room that you were in, Anissa, with the stations. That was so simple and so powerful. And there were 2 that really, really got to me because both my father and the co-founder of our foundation had them for many, many years. But when you did the one with freezing of gait and people had that Velcro with those slippers and couldn't even pick up their feet, I thought that was just so, so simple, but so powerful. And the second one was when you had the thicket where
I
you
forgot that one, and I'm glad you brought it up because it just made me remember. I forgot we did swallowing this
Yeah.
dysphagia, and they had to drink thicket with different fluids.
Yes. And I'll tell you, I can't even tell you all the different brands we went through. And when you think about feeding tube and before that, how you go through all these different ways of what you can and can't eat and how you have to fix your food. I couldn't even stop at that station, but I love that you did it. And I thought that was so powerful. Just think about how much you love your coffee in the morning and how you have to have it thick. Think about being really thirsty and having a glass of water. You can't do that. And I just thought that was so powerful because our co-founder used to have me over for dinner every night because I would share with her what went on at the office because she didn't come to the office anymore. And when she was using all those different kinds of thicknesses for her foods, but she made me eat real food, I wish someone would tell me how not to feel guilty when someone can't eat with you like that, because it was just gut-wrenching every night. But it was what she liked and what she wanted, and she felt like she was really part of the organization. But I'm sure you're going to do it again next year. It was just, and I didn't even know about the berries and a couple other ones because I wanted to make sure I was at my table. But it was such a creative idea and so powerful, and people loved it. And I know that we can expand upon it and make it even bigger and better next year. Great
We
job.
definitely are. bringing it back, and we will expand it. And I did taste the thicket
Oh,
water. It was
I
weird.
know. Yeah.
It was weird. It would be hard. Kelly said that her father used to use it with beer. I can't even
Oh,
imagine having a thickened beer, but he wanted to have a beer with her. And so
what
that's
a
what they
great
did.
attitude he had.
He had a
I
great
love it.
attitude. So, yes.
Yeah. All right. I'm going to put my audio back on and see if I can find that questionnaire quickly.
Awesome. Lori, did you have another thing that you wanted to say about it?
I'm trying to think like what was heartwarming for me is I was struggling that weekend. I was having trouble with my own meds and stuff, and everybody kind of rallied like, you can do this. Like, if you can't do it, don't worry about it. And I just took a deep breath and dove in. And my husband's like, you're not leaving, so sit down at that table and do what you came here to do. So we talked a little about caregivers because he was there with me with a lot of them. And I think there was one other thing that's like, oh, we talked about when you automatically turn and like do they do their notes while they try to talk to you.
Yes.
How that, like, don't do that. Like, we kind of said, like, just get to know the person, like take a couple extra seconds and just take your time, rather take your time. And but they do have a lot they have to fit in a short amount of time.
I found the questions.
Okay.
If you had Parkinson's, what would be your greatest fear? Number 2, what do you think it's like to have Parkinson's? 3, if you got diagnosed with Parkinson's, what hope would you give yourself? 4, how can
We
you
had that one. A lot of people had.
How
Good.
can you show empathy in a 15-minute appointment? 5, how do you use your expectations in patient care to care for your patients? 6, how would you like to be treated if you walked in my shoes? 7, how do you reset when walking into your next patient after dealing with a difficult patient? There you go.
Awesome. I'm
I would
glad
say
we
number
did it.
6 was hard. We couldn't get anybody to understand what that one meant.
Well, I'm glad we had it that way with the questions, to be honest with you, because I think it opened up more interactive dialogue.
That was me with Kelly the night before. I was like,
yeah, and I'm glad you guys changed that, but that's why I didn't have it, because I don't know if she saved those questions. She probably did somewhere, but I didn't have access to them. So thanks for sharing, Carol. So let me give you a little bit of what they said about the experience. And I'm only highlighting some of the data because I'm not going to bog you down with data. But so the eating experience, the eating with the non-dominant hand, 31% say that it was moderately challenging. I know one person said, I'm ambidextrous, really wasn't that challenging. A few people like, it was only slightly challenging. But 22% found it challenging. And the chewing and swallowing, 31% found it very challenging, and 22% moderately, 38% found it challenging. But what I thought was more important was the comments they made. And these are not all the comments, but just some of the key ones. They felt impatient with it. They felt frustrated. They felt talking. I think it was supposed to be taking too long to eat and can't multitask. So that was frustrating. Too worried about spilling in front of others, not being able to do the task that was easy once before, constant mental effort to eat, trying to avoid spilling the food, felt embarrassed and was not motivated to continue eating. And we did talk about some of those impacts. Kelly did in her conversation when she was talking with them, as she was having them do that experience, that it's not just a nutrition issue. It's a social, emotional issue. It's relational issue. It's all of those things. And, you know, a lot of healthcare providers know the impacts of slowing down and, you know, having swallowing issues. We know the risks from a medical perspective, but, you know, thinking about the actual like psychosocial impacts of that is probably there, but not something that they necessarily focus on. And they do want to know your thoughts. And that's why it's so important to have your voices in our programs. And when we do ATMRD, it's important for your voices to be there. They need to hear it directly from those who are actually living with it. So for the gait and mobility station, I just did the ones that found them extremely impactful. The others it was impactful, moderately impactful. So gait mobility station 53%. The SAR3 station, so that was the articulation with the marshmallows, 58%, dysphagia station with a thicket, 57%, taste change, 44%, dexterity challenges, 57%, the Korea station, 23%, but only 60% of them didn't get to do it because there was a waiting line. So I'm sure it would have been a lot higher. The highest, obviously, was the talking to those of you with the lived experience, the ambassadors and the advocates. So you obviously, your voices have the most impact. These experiences are great, but it's nothing to what it's like to talk to somebody really heart to heart that's dealing with this. So that's why it's so important to have you there and being a part of that conversation. So here's some of the comments that they felt. So this was what it was like to go through these different experiences. There was a lot about the gait in there, but they said they felt fear, feeling down, limitation in movement causes limitation in doing what I want, limitation in family activities causes stress. The patients and their caregivers were extremely inspirational, how difficult it would be to alter my current lifestyle from the problems Parkinson's patients face. I move so quickly, I eat fast, I talk nonstop. Frustration, fear, guilt, knowing my experiences were only going to be temporary, that they could walk away from it. Gained valuable insight I never imagined possible. The stations and eating experience taught me how mentally exhausting Parkinson's must be. I take for granted that I can eat, drink, get dressed, walk without having to think about it. Some embarrassment, depression from trying to do things that I should know how to do, but losing the capability of doing things I've always known how to do. And then we asked them which one was the most transformative and memorable. The dexterity. We had several that said the dexterity and gait. They would just simply give up on buttons, realizing how much energy it took emotionally and physically for simple tasks. They thought that was very illuminating. The gait one, they thought that would be really difficult to live with because it simulated freezing and gait difficulties, and I think it replicated what they might feel like. Dexterity challenges was eye-opening to see how difficult it was to perform the activities, the thickening liquid. I love this, something I recommend often, but never realized how unfavorable it really is. And I think that was the whole point of that. Like, if you're telling people to use this, have you ever tasted it? It's not that great because I tasted it. This person said the patient's perspectives was the most memorable. Reminder to ask what is important to the patient and the family. And this one said discussions with individuals with Parkinson's was very insightful. It was helpful to hear about their positive and negative experiences with their providers and how we can do better. I love that. And then how do they anticipate using these insights? So they want to focus more on the dysfunctions rather than the symptoms. And I think what they're meaning is, what are the things that are actually most important to that person? What are the biggest challenges? Because it may not be the symptom that they're seeing. This person said more patience to listen to the patient's perspective, their individual experience, and make the management plan together. This one said it puts into perspective what I tell patients to try and tell them to accommodate to their symptoms, meaning it's one thing to tell people to do something and to make these accommodations. That's a whole nother thing when you actually have to step back and try it yourself. This person said to remember to include the caretaker, the care partner, and to be more cognizant of the difficulties. So that was it. That was just the highlights. There's, a lot more comments. There's a lot of repeated comments, a lot of shared views of how impactful it was, how frustrating it must be, how it really did raise their awareness. So I want to hear from you guys. Like, I want you to go into your breakout rooms and have a discussion. So if you were kind of do this, what symptoms or issues do you wish your doctor, your healthcare provider could understand more to increase their empathy? And if you were to add this experience or add to this experience for next year, because we will be, what would you recommend? What would you include that maybe we didn't include? So Kelly is going to put you in your breakout rooms. Those are your 2 questions to discuss. And let's see, like we have like about 30 minutes, you think, Kelly, and then we can come back and chat for the last 15 or so. I know it's maybe not as long. I talked a little bit long today, but I loved hearing from Carol and Lori directly. All right, so we will see you in 30 minutes. Welcome back, everybody. All right. I am anxious to hear your conversation. So I don't know if you guys want to share. So sorry, this thing is jumping around. What was discussed in your groups? You have talk back. I don't know who was in which group, so anyone want to volunteer?
Carol,
Right, Maria.
Carol, why don't you talk about our group? I think we were group number 1, so we'll go first. But we had interesting conversations or talks.
Oh, you're muted, Carol.
Sorry. First of all, I want to say, Anissa, thank you. It's so interesting. I had between my father and the co-founder of our organization, I have so many examples of what they used to go through. And I loved your numbers saying that our different tables found that really helpful, really helpful. So that I was really concerned about that. So I was really glad to hear that number. I think part of our discussion was talking about what people did talk about and what you brought up in the first part. And Greg was just talking about, he got cut off, about the importance, the importance of having a doctor that really knows how to get both sides of the story, what the caregiver sees and feels and what the person with Parkinson sees and feels. And he was just talking about the importance of what his wife feels. And then we were cut off and put back in this group. But I think that was a really good point. He was also talking about something that I'd never heard of called an Eisenhower scale, where you talk about what your symptom is, and then you talk about how much it really bothers you. And I think that's so important in today's world because we always talk about everyone's Parkinson's is different, and you can't assume anything. We used to assume that tremors and all that was absolutely the number one issue. That's so far from things that really bother people with Parkinson's today, with all the other issues they were dealing with. I thought that was really good. Also talked about what would it be like, because if you have Parkinson's, you have more than one symptom. How about if we have some kind of an exercise where you have more than one symptom at once? Think about trying to drink a cup of coffee when you're out somewhere and you're standing up and you can't move. You have freezing of gait. I just picked those 2 at random. But then Maria said, sometimes you have a lot of these symptoms, but usually it's 2 or 3 that really bothers you the most. And those are the ones that you really want to concentrate on because you have some answers for some of those. Oh, and then he talked about, so many people like Greg talked about PBA, and you can go to McDonald's and start crying at something. And that happened to my father so much. And you don't know how to explain it to people, without going into the Parkinson's things. That's such a good, talking about those psychological issues. That was such a good point. Such a good point.
And
So,
Carol, I think if I can add one thing to that,
please, yeah.
it's the tricks of the trade that give you hope. It's, a fellow Parky telling me, hey, start at 100, count backwards by 13, 7, some odd number,
Interest, yeah.
and the emotion will pass. And I can't explain why it does. I don't know what part of my brain or which of my lobes of my brain is being impacted. All I know is I'm not crying and I can place my order at McDonald's without being upset.
That's the great point. That's the great
Well,
point.
Greg mentioned how important it is to be aware of the psychological aspects of Parkinson's, not just the physical aspects. And he mentioned PBA in particular, but the depression and the anxiety and those kinds of things, those things really need to be addressed because quite often they bother the people with Parkinson's more than the physical symptoms.
And Maria, maybe you can answer this. A lot of people are depressed, not because they have Parkinson's, but because of the interactions of all the medications.
Yes, and having unbalance or unmet, if you're just taking dopamine and no serotonin or epinephrine, you will get symptoms of depression on top of the underlying, depression that may be caused by the Parkinson's. And so it is important to be on antidepressants or something that corrects the serotonin and the norepinephrine to try to balance those chemicals because the brain is usually imbalanced. So when you tilt the scale to more of dopamine replacement, and then you're losing the other chemicals. So that's why it's really important to do that, to be balanced. And sometimes, decreasing the amount of dopamine may decrease those symptoms of depression. But again, would not do it without, consulting with a physician and knowing exactly what's going on.
Right.
So, yeah. But I know about that pseudobulbar. I mean, when I started, I was the same way. I would just start crying for no good reason, and everything. Tears would just trickle down, and I would be like, and it's embarrassing because here you are trying to give a lecture or talk to patients or do something, and all of a sudden you're crying there, and you look like depressed or something. It's like you're having a mental breakdown, but you're like, I can't control these things. Like, why am I crying? It's like I'm happy or I'm just talking, and suddenly tears are just flowing. And so I know about pseudobulbar, and that's why I said that there are treatments, there are medications, and I don't have that problem. So when that usually happens, now it's like, okay, I'm off balance again, and I need to adjust my medication. So it's something that that's one of my first things that I noticed that. If I start suddenly having tears for no good reason, crocodile tears, then it's like, okay, something's up. So.
And Maria, you bring up a great point. I personally believe that exercise helps me tremendously. It's one of the best drugs that I take because it does, in fact, if you exercise properly and hard, it does, in fact, help balance the neuroepinephrine and serotonin, the happiness drug, and stuff like that. You can't just focus on one thing with Parkinson's.
Yeah.
There's no such thing as one thing.
Exactly.
It's a lava flow running over your life.
Yep.
And you can put up all the barriers you want, and it's not going to work. You better kiss your house goodbye and get the pets out or whatever you want to do. But the lava flow is going to burn your house down.
Yeah. No, that's why, you
Point.
with people, with the support groups. That's why we have the PMD to have, the great leaders to do other things to create that balance of life for life.
Absolutely. Okay, room 2, it was Corey, Judy, Karen, Patterson, and Myra. Anyone from your group that wants to share? Did I say Judy? Because I may have missed your name. Who wants to share?
Okay, is it me?
Yeah, looks like you're
Okay.
on.
Well, we kind of segued into other things, but we did talk a bit about improv and how useful that's been for people who have trouble maybe communicating. And let's see, we talked about where our families live in New England. Let me think, what else did we? Geez. Just we talked about people who go to the support group separately. I have people that come. I have care partners that come to my group, but their spouse goes to a different one, and they find that they can be more outgoing about things like that. The things we talked about, we want our doctors to share with our doctors. I think for me, I had, I used to have a problem talking about like constipation and stuff like that. But now nothing bothers me anymore. I talk about what I want to talk about. But I'm very lucky I have a doctor that is easy for me to communicate with. He's like in charge of research and all that. So he's pretty open. Let's see, what else? Karen, Peterson, you had some.
Oh, we talked about how frustrating it is to be just labeled, you got anxiety. There's so much more.
I forgot about that.
Plain old anxiety, and just how frustrating it is in general to be looked at. Well, why don't you look like you have Parkinson's? I mean, I've brought this up in almost every one of these meetings, and it's just so empowering to see everybody have the same frustrations. Yeah, no two people with Parkinson's look alike. And Dr. Michael Oken, if any of you have him on social media at all, he put out 2 really good articles over the weekend. And one term that he's come up with now is demoralization. And I'm telling you, find that article and read it and see if you understand it and see a little bit of yourself in it, because I sure did. And I mean, that one term, I'm looking at kids, in their teens and 20s coming up with this type of social misalignment. And I think if we look at these people in their 20s, these early diagnosed people, part of my mission is to help, help redo how people look at us. I'm really tired of women having to take 10 years longer on average to get diagnosed than a man. And I think if they really look at the psychosocial side, and we keep on sharing our stories to let people everybody's saying here, the emotions are just as bad, if not worse, is the movement disorder. And if we can get these emotions checked early, hopefully we'll get an earlier diagnosis out of all these conversations too.
I have to share, this has nothing to do with us, but in my in-person support group that I run on Friday mornings, we had a visitor come. I'm still laughing about it. And he was saying that he got misdiagnosed for several years. He was an early onset, young onset. And then when he said his 4 years before he got his real diagnosis, he was diagnosed with tennis elbow. because his arm was funny when he walked, and they kept thinking he had Parkinson's, and the doctor said, "Oh no, it's tennis elbow." I don't think I've ever heard of.
And my mom was diagnosed with carpal tunnel first before they finally recognized Parkinson's. So
yeah, I had TMJ for years. Yeah, but no, it ended up being Parkinson's in the end.
Yeah, sometimes you just have to laugh, I mean, it just, yeah. I was lucky because my primary care at the time, her mother had Parkinson's, and she immediately recognized and sent me to see a neurologist. And I thought, oh, that's ridiculous. Well, she didn't mention anything to me. She just said that she thought this neurologist would diagnose some symptoms I was having. And I thought it was ridiculous, but I went. And luckily, he diagnosed me right away. So anyway, I just thought that was funny.
I appreciate the comment about the labels.
Mm-hmm.
And, that might actually somehow try to integrate what it might be like for somebody to be labeled and to experience that somehow next year. So I really like that. I was trying to write down notes. definitely somehow addressing the psychiatric issues. The pseudobulbar effect is really a hard one to try to mimic, but it is an important one, obviously. So in the depression, anxiety, and I agree, like, you're not anxious, you have symptoms of anxiety, and those labels can be very powerful. So that's really good feedback. And the demoralization, I saw that article. It was really good. And we did a talk. It wasn't labeled under demoralization. It was I don't know, a couple years ago, Dan Weintraub, he does a lot of research in that area. I think we talked about different neuropsychiatric issues. I can't remember what we called it. I'm going to look for it and see if we can find it, how we labeled it. But he talked about depression, he talked about demoralization, he talks about apathy, he talked about the different experiences, and these are real things. And if you remember last year, Lori was a part of this at ATMRD. We did a talk on what people weren't disclosing to their doctor, to their healthcare provider, lip sealed. We did the survey. Some of you probably contributed to that. It was very short survey, but it was kind of telling what people were not disclosing and the reasons they were not. This is sort of part of that piece. It's like, part of it is, the biggest reasons that people identified as a fear and embarrassment. And if they don't feel the empathy from their doctor, their healthcare provider, the likelihood of being comfortable, like Judy is now, to talk about constipation or whatever it is. And constipation was one of the big ones, or, urinary incontinence, sexual dysfunction. Those were kind of the top ones. These were like significantly quality of life impactful symptoms, and they're not comfortable having that conversation with their doctor because they're embarrassed or they're afraid. How far can empathy go to really mitigate that fear and embarrassment to help that conversation occur, so that people aren't living with symptoms that potentially could have a treatment, or at least something that could help them, and at least get some support around that? And so there is definitely that piece to it. It's them having empathy to improve the conversation comfort for people. So
And Anissa, when you throw in the factor of the one thing I would like to see for next year's deal, if you're going to go to these tables and have symptom A here and symptom B there and symptom C, that's sort of like Parkinson's, but that's just more like one day in my life.
yeah.
What my life is about is progressive. You go to table A, you take A with you to table B. You take A and B with you to table C. And you take A, B, and C to table D. And you tell me how much fun you're having by the time you get to table D.
Yeah, I love that idea. Actually, Clemmy had that idea. The challenge with that is having enough stuff to be able to get people to be able to take it from station to station. But the impact of that progressive symptom building, and impacting people would be amazing. So if there's a way that you could actually logistically do that, that would be ideal. Obviously, none of these were going to completely replicate what it's like for someone on a day-to-day basis. It is a snapshot of a second, and it's not even a real replication of it, but it's better than nothing, maybe. And that was the hope, to at least start that. But it would be amazing to be able to carry that through the whole thing. So we'll have to turn that around. We have a year to plan that. How could we integrate that into it without it being a logistical challenge? So I know we've gone
That could
over.
be one table in and of itself,
I
where you
agree.
have
That is true.
Velcro shoes and you have ski gloves. I don't like the idea of mittens and thumbs. You can't use your thumb. Nobody on earth.
They could use it inside of it. It's just they didn't have the separate thumb because it made it too easy. We were just trying to make it hard. I don't know how to make it better. Tape their hands. I don't know.
Yeah, big heavy ski gloves make more sense to me because that's more like my hand working in mud, which is what happens when it gets slow. It's not that I don't have an opposable digit. It's just that, hell, I got to tell my hand to do something for about 5 minutes before it starts.
Good
You know,
point.
and pulling, I know my least favorite exercise at the occupational therapist is finding those little damn buttons in the Play-Doh and pulling them out.
Yeah.
Yeah. Well, this has been super helpful, and I appreciate you guys giving this impact or cannot talk the
Input.
Input.
Thank you. That's the word I'm looking for. The input that'll help us to plan for next year and expand this and make it even better next year. So this was a pilot. We just wanted to see how it went and if it actually did have any benefit and if it made any difference from the healthcare provider's perspective. And clearly it did. And so we definitely want to continue to grow that. We also would like it to be something that eventually when we refine it can be something that others can do and replicate, you know, maybe with a toolkit or something in other places. So you guys are so helpful in helping us come up with those great ideas. So thank you.
Quick
And-
thought. Have you been in touch with, what is it, Educate? Isn't it somewhere down around Washington area? It's an organization that treats, you know, that trains people to understand what, well, this is like what older people are going through, because a lot of these things are affecting older people and, you know, whether they put special shoes on or mitts or whatever. Do you know the organization at all?
I do not.
Do you know it, Clemmy? I thought it was somewhere near you. Well, I get information from them. I'll forward it.
Yeah, that would be great. Very helpful.
Okay.
All right. Well, I hope everyone has a good week. And thank you again for joining and for giving us this input. We appreciate it. We'll see you again next month.
Thank you,
Thank you.
Anissa.
Take care.
Guys,
Have a good
bye.
month.